I'm the lead for trauma and mass casualty management at UWE Bristol, and this teaching and learning documentary is going to showcase how we do simulation-based learning.
The heart, see if there's any cardiac motion at all.
Ambulance services.
I feel my legs.
And relax.
And not breathe in, okay?
There are three major teaching and learning concepts that feature in the simulation-based learning that we deliver at UWE Bristol. The first one is relating to a concept called anti-fragility. The second is about selecting the appropriate level of fidelity in a simulation. And the third part is about conducting primary research amongst the learners who've participated in a simulation-based learning activity, so we can have some research-informed teaching and then some teaching-informed research. Anti-fragility is a term that is probably not well recognised within education, but a great analogy for describing this term relates to a novice athlete lifting weights in a gym. Now, that individual would be unwise to select the heaviest weights from the rack and trying to lift those, because obviously they would damage their body. Instead, it would be more sensible to select some of the lighter weights and then over a period of time progressively increase the load. And by doing so, they would create microscopic tissue damage, and then that would lead to strength and growth over time. Now, within simulation-based learning, what we're trying to do is the same process, but from a cognitive standpoint. So delivering exercises that gradually increase that cognitive load establishes anti-fragility in learners. And this is really important because within the NHS today, we've got poor attrition, high rates of burnout, and lots of staff suffering with mental health problems. And this aspect of teaching and learning addresses very robustly those areas of concern and hopefully will enable our learners to have better career longevity. The next concept is something called fidelity. Simulation-based learning has become, particularly over the last decade, quite a complex science. But when we create a simulation, we should really think about the level of fidelity we want to run the exercise at. And there are three distinct tiers of fidelity: low fidelity, mid fidelity, and high fidelity. Now, this relates to the complexity of the selection of equipment, setting, and scenario. But it's not intuitive in the sense that more is better, and that's certainly not the case, and no type of simulation should be considered better than another. It's about tailoring the level of fidelity to the learner or the group of learners you have in front of you. And the recommendation is using low fidelity to build knowledge, mid fidelity to develop competence, and high fidelity to augment performance. And thirdly, it's very important when conducting simulation-based learning activities that we create some primary research undertakings. And looking at the attitudes, perceptions and experiences of students involved in these exercises enables us to generate some data that allows our teaching to be informed by research, and then our research to inform our future teaching. It's therefore really important to appropriately scaffold teaching and learning activities within simulation-based learning. And my advice would be to do this in a three-tier system, to create a technical, a tactical, and a lifelike scenario. So for the technical element, i.e. step one, the recommendation would be to put students through face-to-face lectures and discussion-based learning workshops, and that will build this technical knowledge that they'll need to participate in the simulations at a later time. Step two will be to deliver the tactical aspect of the learning, and this can be achieved through exposing students to tabletop scenarios where they have to critically think and problem solve. Operation Halo is a tabletop scenario which we regularly run on our BSc Honours Paramedic Science programme at UWE. And in the past it's incorporated students from the Physician Associate programme as well as adult nurses. And the scenario depicts a marauding terrorist attack on a London Underground tube station. And the idea of the scenario is that students will practice some of the key concepts associated with major incident and helps them to have the skill set necessary to then move into a scenario where they'll be faced with live actors and industry professionals. And then the final tier is the high fidelity simulation. And this will expose the learner to perhaps the most stressful of activities, but because they've already built the knowledge and the skills, they will be able to then hone that performance.
The module itself has so many parts of it that we're going to be using in everyday practice, which I think is really important, just situational awareness and being aware of how to work with different disciplines. I think that's something we do every single day, and the more practice we get at it, the better, as well as us preparing us for the big things that hopefully we never have to see.
This major incident module is so crucial to being a paramedic because we manage to learn the skills before we get put into practice. We're able to make mistakes where people's lives aren't at risk.
Okay, and if that happens, let's move her into isolation, quiet space, all right? So let's go and do that.
We've produced a variety of videos following each of the major incident simulations that we've delivered at UWE Bristol. Perhaps the most significant of these is our critical responders video, which is a feature-length major incident simulation movie.
November Romeo 444, you're receiving, over?
Receiving, go ahead.
I've got a red call coming in. Female age unknown, unconscious in a garage.
And what we've done in that video, we've staged a deliberate incident chemical exposure, and the responders in the video have been asked to undertake some of the key tasks correctly, some things incorrectly, and some things in a way that stimulates questions and further discussion, so the students can get together in their small groups and go through that to try and identify what actually represents best practice. Operation Jack Screw major incident simulation. There was an aircraft fuselage which was on fire, and this exercise is the largest high fidelity simulation that's been conducted in the UK to date by a higher education institution. It featured 505 participants, ran over 4 days. It had 34 scripted casualties. We had a mock major trauma centre and the full deployment of the emergency services. The exercise also went from the initial aircraft crash right through to a public inquiry simulation. And we were able to utilise a really wide range of resources and incorporate students from 9 different programmes of study.
I played the casualty clearing officer in the Operation Jack Screw simulation, which was quite stressful. And you could see the progression from the start to the end. So the start I was quite timid and I didn't really want to talk to anybody. It was just, can you do this? Can you do that? And then at the end it was like, right, do it. That's what everyone's doing. You're going here, you're going there. What needs to be done, needs to be done. Just do it.
Help us!
The Operation Jack Screw simulation was such a significant piece of teaching and learning. It gained interest from BBC News, who came to campus to film the simulation taking place.
To help healthcare students be better prepared for emergencies, a mock plane crash has been set up by the University of the West of England.
A plane has crashed. There are multiple casualties.
Anybody help!
And they're about to get that help from a very special response force.
Now, first of all, I should point out this is a training exercise. Nobody's actually injured here today, but this whole scene has been set up to help healthcare students deal with a real-life, large-scale emergency.
It's taken 9 months to put together, with members of the police, fire and ambulance services here to pass on their expertise. Scripted actors add to the realism.
We're desperately in help.
And each casualty has a list of their injuries written on them. It's now down to the students to deal with this scene the best they can.
Aviation disasters are quite rare, but that's not what today's about. It's about giving them a chance to see and experience what it's like to deal with major trauma patients, practice key medical interventions, work under pressure and make good decisions. And if they can manage scenes like this, then they'll be brilliant when they get out on the front line, and that's what it's all about.
From one front line to another, casualties were then taken from the scene to a mocked-up hospital, where another group of students were waiting. Quite a day for the next generation of our emergency services.
obviously when we started hearing over the radio, okay, there's been an aviation crash, this has happened, we're like, okay, let's get our bags ready, let's get things going.
There's people, there's smoke, there's what am I going to do next? Okay, I've got to do this, I need to get that out of my pocket, like my hands were shaking, but then after a couple of minutes I'm like, okay, it's fine, we're in the flow of it now, this is what needs to happen, I need to get people to do this, I need to get people to do that, this is where we're going, and actually it was great.
Major incidents do happen, they can happen to crews on the road, and you won't get any warning about it. We're really lucky we got a warning that we were going to come into uni and there might be a major incident, but coming in today was fantastic.
And it's this kind of experience that will hopefully help when it's not so fantastic, when they have to deal with a disaster for real. Andy Howard, BBC Points West at the University of the West of England.
The activity also helped UWE Bristol win TEF Gold status for teaching excellence, and has since been an activity that people always talk about at university interviews, and it's also helped develop our National Student Survey results.
Okay. Yeah, access.
Operation Spike depicted a traumatic cardiac arrest in a nightclub following a stabbing. And when the paramedic responders arrived on scene to treat this emergency call, they realised lots of people in the club had also been spiked. This project was very important for raising awareness about drink spiking, particularly amongst our undergraduate students, and improve treatment pathways for those that have been affected by this terrible crime.
Cardiac arrest in there and some other stab wounds.
We integrated Avon and Somerset Police in this activity, and we had trained actors who were the suspects in this scenario, and they had to be chased, detained and then arrested. In 2023, we ran a major incident simulation, Operation Rewired, and this simulation depicted a serious house fire caused by the contemporary crime of meter tampering. Occupants within inside the house had set up a cannabis factory in the upstairs bedroom, and they'd rewired the electricity meter to power the lights to grow the cannabis farm. Multiple responders from a variety of emergency services were deployed to the scene, and we had trained actors inside the house that needed to be rescued from the upstairs windows. Some of them had jumped to escape the flames, and there was lots of traumatic injuries for our student healthcare professionals to treat.
Rosie, do you know where you are at the moment?
Ambulance waiting to go to hospital.
Okay.
I need to find my flatmate.
In 2024, we delivered a scenario called Operation Cholinergic. And this major incident simulation was an agricultural disaster in which a group of contractors had been brought into the university to spray some pesticides on the plants as part of a nature reserve renovation project. But what they didn't realise is they'd been given incorrect quality personal protective equipment and therefore exposed to organophosphate poisoning.
So we were kind of liaising with the operational commander, with the loading officer, and also with like the HEMS team, just to make sure the right patients were going at the right time and everyone was in the right place, kind of priority-wise. Yeah, just overall overseeing it pretty much.
What we've got here is a group of physician associate students and occupational therapy students, and their job is to do the initial assessments, be able to address whether there are any critical needs for these patients for ongoing care, and then manage where they go from here.
And for many of these exercises, what we'll do on completion is ask our policing colleagues to take witness statements from all of the responders involved in the major incident simulation. And this is great practice for the students because it gives them a chance to go through their thoughts and compile a witness statement in a very lifelike fashion. And then what we do is we compile that evidence to create a courtroom simulation.
Ladies and gentlemen, please be seated. This is a public inquiry into a serious incident at Vauxhall train station.
I do solemnly, sincerely and truly declare and affirm that the evidence I shall give shall be the truth, the whole truth and nothing but the truth.
Much of this evidence is integrated with work that our forensic science trainees are undertaking, so they will come to the scene upon completion and collect evidence which then feeds into that courtroom scenario, and through the help of some trained barristers we're able to craft a courtroom case in which our students can come to the witness box and give evidence in a coroner's court or a public inquiry simulation.
Ms. Bennett, given that you had multiple patients with the same clinical priority in your casualty clearing station, how did you decide in what order the patients would require transportation to hospital?
So I had a medical advisor as well as the casualty clearing station.
The courtroom simulation was quite important for me, as I think it's quite a daunting thing to go into a courtroom, stand up, give evidence, which is obviously quite common in our practice to have to go to court, whether that be a public inquiry or a coroner's court. The courtroom just gave a complete different experience and it felt so real.
Mr. Davenport, did you have sufficient resources and emergency services personnel to efficiently manage the scene you were facing, Mr. Davenport?
Initially, I would say no. We needed resources as quickly as possible, and it took some time for those to gather.
I had quite a key piece of evidence. I had the pilot of the plane, who was my patient in the casualty clearing station, and I had to give evidence on how he appeared to me at the time. Luckily, I just referred to my statement. It's quite nerve-wracking to be in there, to be honest. You've got a proper judge, and you've got lots of people sitting there. You've got the families, paid actors. So even though obviously it's all a simulation, it was still quite nerve-wracking to go up there and to speak and then get released. And we didn't really hear much else what happened with the prosecution or anything. It was just part of the experience.
The court has already heard that this incident was under-resourced. I think Mr. Davenport concurred with that view. Mm-hmm. Can you explain then why you felt it was important to not split up and work together as a pair?
Well, it's a very, very high pressure situation, and I believe if you're doing it one person for each patient, you wouldn't be able to assess and manage the patient as well as we could have.
It was quite nice to have some feedback from the barrister as well at the end of the courtroom exercise. He told us to be confident, stand, say exactly what we said in our witness statement, stick by our witness statement, use it to refer back to, and to face the judge when you're answering questions. So although the barrister's asking the questions, you answer to the judge. It just makes you appear more confident and that you know what you're doing, you're confident in your own practice.
I was deliberately keeping you a little bit on edge, but John is right to say that you could expect to be grilled, particularly in those circumstances, by the family.
When thinking about fidelity in simulation, it's also really beneficial to think about the utilisation of Panicucci's theory of learner development. Now, this model has been adapted for higher education, and the analogy looks at an archer's target with various rings. The centre of the target represents the learning zone. And from an educator's standpoint, what we're trying to do is place all of our learners at that sweet spot where maximum learning gains can be achieved. But that's easier said than done, and what's more likely to happen is teaching and learning delivery will place learners into the next ring of that target, which is the comfort zone. Now, in this space, learner gains are not optimised because these individuals are not subjected to feelings of discomfort or pressure, and so no real gains are achieved. But equally, the cognitive load of the exercise surpasses the level of that learner. What they'll end up in is the outermost ring of this target, which we refer to as the panic zone, and similarly, learner gains will not be activated in that space. And this is because learners will subconsciously feel overwhelmed by the experience and they'll retreat to the comfort zone. So historically, major incident training is very much focused on giving learners that clinical acumen necessary to be effective in real-world incidents. But in my experience over the last decade, from a clinical standpoint, mentoring students and staff within the NHS and also conducting primary research in higher education, there are actually two other dimensions that need to be focused upon. The second of these dimensions is emotional preparedness, and the third concept is mental resilience. Now, these three concepts reside within a sort of triangle format, and actually students that don't have all three of these elements are more likely to suffer later down the line. And so it's our role as educators to make sure we've provided skills and knowledge within these three different areas to maximise career longevity.
rate 106. And we're about a minute and a half away.
Can you get some fluids ready for us? Thank you. Lie back down completely. I'll give you some more clean, right, for that pain.
It's really important to engage students in experiential learning theory, and utilising David Kolb's reflective model is really, really valuable in simulation-based learning. The model represents a cyclical process with 4 separate components. The first part is a concrete experience, and this refers to the simulation itself that the student has taken part in. The second part is a reflective observation. So they think about the things that have gone well, things that maybe didn't go so well, and things they might do differently if faced with that incident in real-world practice. And that then allows them to move to the third section, which is about abstract conceptualization. So thinking about very specifically, how does this learning change my future practice? And then the final component of Kolb's model is the active experimentation. So when they then go to that next incident, they can utilize those new skills and that new knowledge they've acquired. And it therefore wouldn't matter whether you had a brand new Year 1 student going through this model or a 20-year qualified clinician, because whilst their learning might be very different in the scenario, they're going through the same process to improve their future practice.
Radial pulse. So that's 92 on air and 99 on 15 litres O2.
It wasn't hypoxic on scene, but it's just because of the carbon monoxide poisoning.
So we had a range of patients coming in from very high critical ill to walking wounded. Try and put all your weight down.
We basically had to divvy up into different teams. Certain nurses went to trauma, certain nurses went to minor injuries, majors, and then we split up into having a triage nurse and a emergency room coordinator. Sort of decide that between ourselves, decide the equipment we needed. At the beginning, I was like, oh my god, the parents handing things over to us, didn't really know. But actually, by the end, you get into the swing of it and you start remembering people's roles and where they're going. And we were going through patients a lot quicker.
So let's get her on some oxygen. How much do you think she needs?
15 litres?
What we're trying to do is bring them into seeing some of the more refined aspects of what happens with trauma patients. You know, we teach radiographers, they must know exactly who their patient is. In a major incident, we actually just number patients that are coming through the door, and we deal with them as numbered. So this is the third years learning that. The first years have never seen a real injury, but what's happening is the third years are passing their knowledge down to the first years. So they're peer-assisted learning, which is really important.
And you have at least 2 or 3 people here. We're just getting, P1, but we need a pelvic binder.
The whole major incident simulation is hopefully preparing us for something that we never have to go and see. We don't want to ever go to a massive tragedy, but in reality it could happen. So preparing us for that is really important to get us to know how we need to organise, how we need to communicate with our team members and with people we've never met before, to know what is expected of us as well in that sort of scenario, and to sort of understand how everything can sort of go wrong when there's a load of stress and things that you've never seen before.
We know that major incidents happen every day, and quite often people are not prepared. But UWE students are prepared because they do get the opportunity to work together to be able to manage these critical occasions.
My experience with the major incident training was quite daunting. I was quite terrified, but towards the end of it I felt a lot more comfortable, and I think that in practice I would be comfortable now to go out to a major incident and play any role.
So I hope you've enjoyed this video and some of the content has been useful for helping improve simulation-based learning at your institution. And if you have any questions or you'd like to get involved with some of the events that we run at UWE Bristol, please feel free to contact me on the email address shown below.